Dr. Sadia, my question to you, and let me ask the questions to those who are opening their exams. Okay. Just to check your preparation, tell me how will you approach patient who is acutely under?
Hello, good afternoon. I can see.
No, I don't want you to say that. I just want
Good
to tell
afternoon.
you what simple words.
I can see from my notes that you have gone to the study because you have.
Acutely unwell patient, you've been called by a nurse that there is a patient who is not responding.
Okay.
What will you
If
do?
not responding, then first we will call out the
Okay.
patient. If not, then we're going to check the airway why that patient is unwell. Is that right?
Yeah.
Okay, so once the airway is not normal, if it is below 93 or 94, the oxygen levels, then we're going to apply the oxygen to the patient.
Zishan, is there anything different that you do from here?
First, we will check the response.
Mm-hmm.
Where like tapping on the shoulder, asking for his leg.
Okay.
If his airway is intact, then we will change it. If his airway is blocked, then we check.
Amber, you? Thank you.
The name is the patient's name is James.
Okay. Yeah. Whatever.
So James, can you hear me? Can you talk?
Okay.
Then
So, in simple words, you will try to get the response. Okay? So, can you paraphrase this? Like, I will try to get the response instead of start reading the script that from your notes and from this and that. So, interaction, try to interact with the patient, try to get the response. James, hello. So, this is what is expected. When you go inside your cubicle, you have the patient and everything. Now, what is a SimMan? This is very important. What is SimMan? What do you understand from the SimMan? Is it just a document? SimMan, what do you think? Simulated man or simulated human, okay, that can simulate in the GMC exam. It can develop the tongue swelling, can blink the eyes, and chest wall movements. There are the sounds and the beeps in the background, okay. You have the murmurs, you have the respiratory sounds, and those sounds, okay. Why this is important? It used to be at some stage back in the past, in the year 2016-17, up until 2017, it used to be a mandatory station where you had to pass this to pass your exam. And now this is more standard, general scenario, okay? Because now nearly everyone has to do their ALS. As soon as you start the job or even before you start. Just check on the YouTube page. So, why this is important? They want to see that you have the skills to save a patient. You will be working in 2-3 different shifts. Morning, evening, afternoon, or nights. Okay, so there are different shifts. And during the day, normally most of the time, the weeks between 8 and 5, you're most of the time accompanied, you have many of the people on the board working with you. But after 5 o'clock, you will be alone. As an SHO, you have the responsibility to act when someone needs any help. Okay? And you may have many tasks as well, like discharging patient or putting the cannula. They want to see do you have the skills to prioritize when something goes wrong, when someone needs any help. Okay? So these are the important things that we want to see. And when you see any patient, you can be anywhere, regardless of your location, the situation. Are you able to save a life or a limb or an organ. That's it. So this is why we need this SimMan to see all those things. There is no different approach when you are working in the gynecology department for an acutely under patient in comparison to someone who is working for the neurology department. So there are few things that can kill the patient. You do not have a different approach for the pulmonary embolism for the blind patient in comparison to pulmonary embolism or RD patient. Okay. You need to follow some structure. ABCDE is actually the Resuscitation Council has kindly helped us by creating the ABCDE book. Okay. What is the ABCDE? Airway, disability, exposure. Okay. Fatima, you Fatima? Mariam, you tell me, what do you understand from disability? That's one of the common questions in class. What do you understand from disability? What is a disability? You guys are going to help me with this ABC. Okay? ABC. Sorry?
See if there's the patient can move, if there's a functional impairment, for example, an injured limb.
Okay. How that functional impairment will kill the patient? We're talking about something that can kill the patient. How is that going to kill the patient?
For example, cervical.
Anyone who can anyone who can tell me truly apart from
Well, I think disability part is to check the glucose level, right? And that will be checked.
the glucose is one of the parameters.
It can be any. It can be like hearing difficulties or problem with hearing.
How can
It
that-
be oral.
How can that kill a patient?
Stability in case of fractures, excessive.
How can an unconscious patient, only body, who didn't have any fall, no RTC, okay? Why are you expecting that
Because they
fractures?
cannot explain and between disability.
Sorry,
It is in different.
that because
Now, what is a disability?
So in your lecture, I'm taking your lecture and you told it's basically the neurological assessment. Neurological assessment you do in the it's basically brain function. Is it functioning properly or not? ABP,
That is the right answer.
we follow ABP protocol and stuff.
Yeah, that is the right answer. That is the right answer. Okay? So, this is what I want to know. A is the airway. B is breathing. Circulation. Disability. Okay? Airway, breathing, circulation, disability, and exposure. Now let me explain what does disability mean. It's a dysfunction of the brain. Okay? Or dysfunction of sensorium. Okay? You understand what is a sensorium? Consciousness. Sensorium means a consciousness. Dysfunction of the consciousness is a disability. Okay? I'm not worried about the arm weakness, for the leg weakness. I'm not worried about the disability of one eye that you cannot see. Okay? It is mainly about the consciousness, dysfunction of the sensory, okay? Or disability of the brain function. Alright? So that is it. Why it is in this order? Can someone bother?
Sir, it is in this order because, sir, like airway can kill a patient rapidly, then breathing, and breathing can kill rapidly, then circulation and so on.
Excellent. Yeah, that's the right answer. It's not because it sounds easy, or it's easy, or it sounds beautiful, we can sing ABCDE. It is for that reason, because A can kill the patient before B, and similarly B can kill the patient than C. Okay? So we need to follow that particular order of assessing the patient whenever we see. Okay, now airway can completely airway compromise, full airway, absolute airway compromise can kill the patient in about 3 minutes. Okay? And breathing or the complete respiratory collapse can kill the patient in about 5 to 6 minutes. Especially breathing and airway can low. Circulation, it takes about 10-15 minutes. That's why you must have read about the sepsis in the show. Okay, we want to start the treatment as soon as possible. I believe all the patients who are septic, they should receive all the protocols, sepsis 6 protocol within 1 hour of their arrival in the hospital. Okay. Disability, we talked about that, exposure. Okay, when you are called to see any patient, you need to follow ABCDE protocol. The aim of your assessment has to be to get answers to 2 questions. Number 1, whenever you're doing this assessment, is A stable? And will it remain stable? These are the 2 questions. The patient may come talking to you, but they may stop talking also. The patient with anaphylaxis, they come talking, okay, after some time, they can develop swelling, and they are not able to talk. Similarly, when you start seeing the patient, you check the blood pressure, it was good, you're happy. But what answer you need from yourself or from your assessment? Will it remain stable as it is now? And you aim to make it better, when you will never accept the deterioration. You never want to deterioration. Okay? But whenever we are assessing the patient, normally we look for reversible causes that can cause disease. Reversible causes of deterioration. Because irreversible cannot be reversed. What you are looking for is any hypoxia, is any hypertension, is any hypoglycemia, so that you can reverse. And you correct them as soon as you identify. Okay? To make it easy, the Resuscitation Council has given 4 H's and 4 P's. 4 H's and 4 P's. I want you to help me with this. What are the 4 H's and 4 P's? Okay, you got hypoxia and hypoglycemia.
Hypotension.
Okay, hypotension. What else?
Hypokalemia.
Hypo or hyperkalemia. Okay, So these are the four H's, these are the common reasons, common reversible causes which can kill the patient. Okay? Hypo or hyperkalemias or hypothermia. Okay, so these are actually four H's of acutely unwell patient that we want to rule out. Is any hypoxia? Is any hypoglycemia? And you won't get the answers by following ABCDE. Okay? Can this be hypoxia? Can this be hypoglycemia? Can this be hypertension, hyperkalemia? Or can this be hypothermia? And there are 4 T's as well. Okay, when you are assessing any patient in research, in A&E or when on the board, we have the chart available to rule out 4 H's and 4 T's. It is printed on there. What are the 4 H's and 4 T's? You need to follow. Okay. So what are the 4 T's? Sorry? Yeah, 4 T's. We have tension pneumothorax, yeah. What else? Cardiac tamponade. Okay. What else? Toxins. Just one more. Thromboembolism, PE. Yeah. Thromboembolism. So most of the time it's a PE. Now, if you go back, if you are aware of your structure, your exam scenario, nearly all of them are covered in the course. Hypoxia, okay, opiate obesity. You understand? Opiate obesity causes the hypoxia. Hypoglycemia, hypertension, PPH, postpartum hemorrhage patient. Hypoglycemia very typical because of the alcoholism, because of skipping meals and those things. Okay, hypo or hyperkalemia can be because of the electrolyte imbalance in the renal failure patients, so CKD or any other form of septic patients as well. Okay, tension pneumothorax, very unlikely for your scenarios, but it can at some stage become a part. Say, for example, you go to see a patient who is acutely unwell. Usually, this is a scenario related in ATLS. ATLS, acute advanced traumatological assessment scenarios. Okay? We expect that this happens, but it can also happen on the boards in patients who are symptomatic stuff. Okay, central venous hemorrhage. You see, the line is just put in, and then you go also when the patients are being unwell, you're told by the nurse to see the patient. Okay. And you see the tracheas, like it can happen there, but they have not assessed that in the PLAB exam. Alright. Better you be ready and think out of the box if it comes. Okay, when we see any patient, so you need to follow ABCDE. Do not listen to scripts. Don't follow the scripts which are being wrong developed in the market, okay, in the rules. Okay, these rules and everything is just to help you, but not to follow. Do not believe that everything will be as it is written in the rules. Okay? Does it make sense? So follow the structure A, B, C, D, A, B, C, D. And these are the reversible causes that we want to look for. If there is none of them which is listed on here, that means the patient has some irreversible problems. Very bad. And they can clinically see very quickly. Okay? Okay, now about A, B, C, D. How will you make sure that the patient's airway is patent and stable? How do you make sure that breathing is patent and stable? Do you have any way of assessment?
If a person is speaking, his airway is breathing.
Okay, and will it remain patent? So two questions that we need to get answers to. For every single assessment, two questions. Is it stable? Will it remain stable? Okay? If you get the answer yes to both of them, then you move forward. Okay? Now, about any problem that you find in airway breathing circulation, the rule of thumb is you intervene immediately. You start the treatment as soon as you suspect, not diagnose, as soon as you suspect. Okay? If diagnosis is easy and quick, you wait for the diagnosis. But otherwise, if you suspect, start the treatment. Alright? Now, A, B, C, D, E. That's a progression, vertical progression from A to B to C to D, E. Okay? And there is a horizontal progression. What is a horizontal progression? Within A, within B, within C, that is applied within one system. Horizontal progression system is within one particular system. Okay? So, which is it? Assessment. Intervention. And diagnostic problem. Or investigations. Okay, so investigations is a kind of your part. You know, when you go to superstore, okay, you pull the card from outside. So you take that card and keep adding your investigations in there, and you do that just towards the end. Okay, you pay the bill, you go to the bill and ask, you want to buy this. But the remaining part that we have to do is assessment and intervention. These are the immediate actions which are expected from you to be doing. Okay, now when you go inside the cubicle, there is a patient and there is a monitor that you can see over there. There is a patient here, there is a monitor on the side. We need to follow A, B, C, D, E on the patient. Okay, so what did we tell you? We have two things: a patient and a monitor. I'll try to make it easy for you so that you can understand, you can remember. We do follow A, B, C, D, E on the patient. There is nothing to follow. So you have nothing for in the end. Always, when you do your assessment, it has to be A on the patient, A on the monitor, B on the patient, B on the monitor, C on the patient, C on the monitor. Okay? So which means that you are assessing the patient and confirming, you are making an assessment by using your technical skills, your assessment skills, and you're confirming the findings on the monitor. Okay? You do not waste a lot of time in doing the respiratory, calculating the respiratory movements. You are not wasting a lot of time in counting the blood in 1 minute because the patient is acutely unwell. So you need to just simply feel and look for certain parameters. And if you are happy with them, you say confirm that with the monitor and move forward. Does it make any sense? Mariam? Ahmed? Zishan, is it clear? Okay, now we have to, which means that we have to do A on the patient, confirm A on the monitor, intervene according to the patient's needs or based on our assessment, and put the list of your investigations in the part. Okay? Create the list, put the investigations in the part there, and identity, all of them. So you try to create this list. Okay? Now, how we can do the A? How we can confirm the patient's behavior is different. There are two ways: visual assessment and auditory assessment. Visually, can you see anything? Any rash on the face? When it comes to the patient may still be talking, but when the patient remains talking, there's the next question. Many of the time, the patients with anaphylaxis, they come talking and they develop their reaction. Many of the time, the patient with chemical or inhalational injuries, they come talking, okay, but they develop their brain injuries and their complications. The patients who are stuck in a house on fire, they develop their brain problems and they develop their compromise. Very common in Pakistan, there are so many incidents happen in one university. You might have seen the cases in one university, and they normally put on ventilators even if they are talking. Or many of the time they have to have a tracheostomy because they compromise even if the patient has come talking. So they need to get the answers to those questions. The typical scenarios that you can see in the routine practice, although this house on fire is not very common in the UK, but other situations which are common, blood transfusion, it can be done, reactions, anaphylaxis, peanut allergy, or allergy to penicillin, antibiotics, they can be done, reactions. So always think about that. Talking to the reason when you start the treatment as soon as possible. Okay? Now, you assess a patient by talking to the patient. Okay? Or this means that visual assessment everything involves both talking. So, when the patient is able to talk to you, make sure that you are aware of look into the tongue, look into the lips. Okay? So, it means that even if the patient is talking to you, it is important that you ask the patient, show me your mouth, show me the tongue, look at the because you as a doctor won't get to that. There is nothing like this. What are the worrying symptoms when the patient is able to talk or they making some sounds but they're still worried? short of breath, okay? Yeah, we can say to some extent that maybe mainly because of the anxiety, but not
Yes.
primarily from, yes, gasping and making some moaning sound, the patient gasping, or the whistling sound, the croaky sound, or the strident, okay? Or,
Angioedema.
sorry?
Angioedema.
Angioedema, we can see any swelling, if the patient is still talking, the speech is not very clear. In that case, you need to be very careful. If the patient has some gurgling in the throat, okay, and they're not able to clear their throat. I've seen a patient who was not able to clear his throat. I think he's like, I have something stuck in my throat. There's a sputum, he was trying to spit the sputum out, and it just stuck to the floor, and for 3 days, then it started causing a disturbance to him, and he was not able to tell it. He needed clearance. Many of the time we need the suction into the mouth to clear the throat. So such incidents can happen, especially those with lung swelling, neurological problems, like the weakness as well, those kind of things, and those who are elderly who have the swallowing problems. Okay? So it can happen with them as well. Anyhow, for the sake of your exam preparation, look into the mouth, look on the tongue, the patient's tongue may be some swollen, lip may be swollen. They may be rash on the chest as well, rash on the face as well. Okay? So these are the signs and symptoms. So we assess the patient, we talk to the patient, look to the mouth, okay? We are happy. What did you say? What's the next section that you need to do after this? After doing your assessment with the patient?
Looking at monitors.
Look on the monitor, confirm that is actually right or not. Or is my assessment matching the numbers on the monitor? So the first thing that you go to look on the monitor is SpO2. Okay? So auditory and visual assessment on the patient for A and SpO2. Check SpO2. Okay? So these are called the parameters. SpO2 is a parameter. These are the parameters of assessment. Okay? No tongue swelling, no lip swelling, no swelling of the uvula. The patient is able to talk clearly. So these are the parameters of the assessment. So we move from patient to monitor. Okay? Then investigations and the interventions. Is there any intervention needed for this patient?
So if oxygen is low, then we need to put oxygen.
How low?
So less than 94.
Anyone who can answer? You have been the brilliant student so far.
If it's less than 94 in normal patients and less than 88 in COPD,
Okay, now I will try to show you on my monitor. Okay, now this is a monitor that you will see. Uh, this is a slide that I want to show you. 94 is normally in those who are stable and do not have anything worrying. Okay? You might have heard of news score. News, that's a national early warning score for the assessment of an acute vulnerable patient or for the assessment of a patient. Okay? News score, national early warning score is a system, is a scoring system that is used normally to triage a patient, to prioritize a patient. Those who need urgent assessment, urgent intervention, they score 1. Now if you look on this number, 94, go to this scale 1, okay, SPO2 scale 1 and SPO2 scale 2 is for the COPD patient and 1 is for the normal patient, normal individuals. Look in the middle, 0 is for those who are scoring more than 96%. Okay, so which means that when a patient is acutely unwell, we aim to keep the oxygen above 96%, 96% or above. Okay, otherwise, if you are based on your score 94, the patient will still be scoring 94, 1. Okay, so their new score will be 1. Based on if the oxygen saturation is 94 or 95, they will have a new score of 1. And a new score of 3 is a trigger for escalation. When the nurse will say, they check the new score of the patient with the triage. If someone has a new score of 3, they come straight to the doctors. If the patient's new score is 1, only 1, for any reason, say for example, it's just the oxygen saturation which is 94 or 95. Let's say, okay, the patient is stable. You can wait here, I'll call you once your turn comes. But when they start scoring in other areas like the pulse and the temperature, okay, then the score will go up and the nurses will escalate. Score of 5 means escalation to either majors in the emergency department or the resuscitation area. Okay? Means that we are aiming to keep the oxygen saturation of the patient 96 or above in the normal individuals, and those who have COPD, we are aiming to keep their oxygen between 88 to 92 without with the oxygen, without the oxygen, and 93 to 94 all oxygen. So we do not want it to come below 88 in any case. If the patient needs oxygen, you give them oxygen. Then in that case, try to aim to keep it. The maximum height is at 92. If the patient's oxygen goes above 92 with the oxygen, 93 and 94, they will score 1. Okay? So means that they are shifting to the unwell side. So the well side for them is at 88 and 92. So that's the range. Does it make sense? Okay, now answer to your question, it is we need to start the patient on oxygen if their oxygen saturation is below 96% and the patient is not on the CO. That is the range. Is it making sense? Clear?
So do we need to remember this news score for?
No. I'm using many tools just to make your understanding clear.
Yes.
So you don't need to.
Sir, I have a thing.
Uh-huh.
If my patient is talking to me and the oxygen saturation on the monitor is 95,
Yeah.
isn't it like I have to monitor?
Yeah, you can
We don't need
monitor.
to put the oxygen mask
You-
at that moment. We just
you-
have to look after if it's dropping below 92. Like we have to keep the observation close. I didn't get
No,
it
you,
basically.
you, you, you will not be sitting just with the patient all the time and monitor.
It means you want to say that if it's below 96 in the exam, we have to give oxygen mask to the patient.
No, that is a best practice. That is a best practice. That you highlight, okay, my patient's new score is 1. If you want to, if you're very proactive, you can say the patient's oxygen saturation is below 96%. Ideally, this is a new score 1. But I'm happy otherwise. The patient is talking, I'll keep an eye. I will not start the oxygen at the moment, but maybe to start. So, but you need to give some reasonable explanation of your actions, what you are doing and why you are doing it. Does it make sense? Yeah? You do not have to do, there are certain actions that you do not have to do without any reason. Okay? The patient's oxygen saturation is 96%. You can simply acknowledge that. If the patient's oxygen saturation is 95%, you can acknowledge and not start the oxygen. But if it is 94 or below, not starting the oxygen is a crime. Okay? Otherwise, at 95%, you can simply say, I'm happy with the oxygen, I will keep an eye on you. Okay? I prefer to start the patient with oxygen because oxygen is not going to deteriorate or cause damage, especially if the patients are not known to have CO2 retentions. Okay, for the sake of your examination, I normally prefer to start the patient, look in the patient's mouth, there is no worrying signs and symptoms, start the patient with oxygen, and tell that, let me start your oxygen, let me give you a bit of oxygen. I will take it off if you don't need. At the bottom, let me carry on the assessment. It takes just a few minutes. Okay? Now, what is the investigation, Baba, that you can do? So we are following this pathway. Assessment, okay. Then we move to intervention. Okay, so here we will give the patient supplementary oxygen. Okay?
Yes.
So that becomes our intervention. Is there any investigation that you can think of?
X-ray.
ABC. ABC, okay? X-ray will not tell you if there is any problem with the clear.
Right.
And ABG or the VBG, if the patient's oxygen saturation is normal, patient does not have any hypoxia, and you can do the VBG. But hypoxic patients need ABG. That's very important. Okay? Any confusion or question? So we completed our movement. This is horizontal progression. Assessment, intervention, and investigations. Assessment, intervention, investigations. And our pattern of assessment is A on the patient, A on the monitor, B on the patient, B on the monitor, C on the patient, C on the monitor, D on the patient, and ABC on the monitor, E on the patient, ABC on the monitor. Okay, so we need to follow A, B, C, D, E on the patient and A, B, C on the monitor. Okay, very bad habit that we don't know. Most of the doctors don't know how to read a monitor as well. Okay, they simply just start chasing the numbers, whereas they do not have the sense. Okay, monitor is just to tell you the numbers. Okay, that is not the patient. We don't treat the monitor, we treat the patient. If the patient is stable, but the numbers are going down or up, okay, that's better do the assessment of the monitor, on the patient, rather than worrying about the monitor. Okay? We need to do the clinical correlation. Is it making sense? Okay, now that is our horizontal assessment. Now, after completing this, we did the assessments of the patient. Say, for example, Mr. Smith, and I came to Mr. Smith, started talking, and he is answering me. I looked in the throat, there is no worrying symptoms, no suitable nostril, and the patient is breathing comfortably, there is no gargling, spider, or any worrying signs and symptoms, and there are no rashes, there is no swelling of the lips. Okay. I will express, I will talk to Mr. Smith that I need to give you a bit of oxygen, but before that, check oxygen. Okay. Odometer and if the oxygen is low, then give the patient a bit of oxygen in the non-need breaths. Just wait for that. For breathing, we move forward and do the assessment. How are you going to do the assessment of breathing? What's your name? Noor. Okay. I will try to do this.
If it's viral, insignificant or not.
Okay, you need the examination, inspection of the person. Okay. We need to do the assessment of breathing by clinical examination. which is inspection, location, depression, and host location. That is a clinical examination. Plus visual assessment again on the patient. Is there any visible respiratory distress? The patient may have any signs, worrying signs, pursing of lips, okay, use of the chest muscles, that we can know the patient's breathing is under problem. Okay, the patient has an increased work of breathing. Okay, when they have to breathe a lot. And then you go to the monitor and look on the respiratory rate. Okay? Be on the patient and be on the monitor. First of all, you look on the patient, do your assessment, and match your assessment, confirm your assessment with the monitor. Okay? So we are going to check the respiratory rate. But it is always important when you have reached this phase, A and B, when we have done your A and B together, we need to put them together and do the assessment again, okay, of the entire respiratory system. Whether the respiratory system including A and B in combination are stable or not. Okay? So we don't treat the numbers, we treat the patient. The numbers, there is some rule. Okay? I will just show you a few examples of how ignoring one number can impair your assessment. Say for example, we have a patient called X, Mr. Y, and Mr. Z. Okay? SpO2, respiratory rate, and then supplement dose. Say for example, Mr. X has oxygen of 96% on room, 96%. Mr. Y has 94%. Mr. Z has 92%. Okay. Who do you think is the most unwell patient?
Z.
Mr. Z, yeah. But if I tell you that this patient has a respiratory rate of 40, this has 30, and this has 20. Who is most unstable? Mr. X. Yeah. Now your assessment has changed. Always make sure that it's not only one thing. There is not to be seen in isolation from breathing. So airway and breathing together build the respiratory system. So you need to do the assessment again based on A and B. Okay? Just until the assessment of airway, the patient may not need oxygen. You may simply say, I'm happy with your oxygen. Okay? Let me carry on your assessment. Then we do the assessment, we listen to the chest, we form some worrying symptoms. Okay? There are the breathes, there are the palpitations, the patient is breathing 40 times. Now, your intervention has changed. You can tell the patient, Mr. Smith, you're breathing very fast, let me give you oxygen. Even if the oxygen saturation is 96%. Because if he continues breathing 40 times to maintain this, he's going to tire very soon. He's going to tire very soon. And then the process of deterioration will start. Will kick in and start making the patient on that. Okay? So you want to stop a bit, maybe give a bit of oxygen to the patient so that he starts breathing 30 times, then 26 times, 25 times slowly goes. He gets a bit of scored by additional oxygen, otherwise he will be breathing very fast. Okay? Now, if I say that this patient is breathing on room air. This patient is requiring 50 liters and this patient is requiring 2 liters. Who is the most unwell patient?
Why?
Mr. Y.
Why?
Isn't it?
Yes, sir.
His oxygen saturation is low, he's breathing 30 times and he's requiring 15 liters. High flow oxygen. Okay? Now the assessment has again changed. We cannot simply make the assessment based on one single parameter on A or B. Okay, so after you complete your A, do your B, and then put them together and see if the patient's respiratory system is stable or not. Okay, you must have heard of the cardiorespiratory arrest. Okay, most of the time the patient either develops a cardiac arrest or the respiratory arrest. That's why it's cardiorespiratory arrest, cardiopulmonary arrest, or cardiorespiratory. Okay? So these are the two systems that can put the patient in arrest. The respiratory arrest or the cardiac arrest. And they will need further measurement when they develop this test. Okay?
So, how will we do this inspection, palpation, percussion, and auscultation?
On the patient, yeah. So you need to tell Mr. Smith, let me examine you, okay? I need to expose your chest and you do the assessment. The SimMan will be able to look on the chest wall. Okay? And then you need to report on the chest, take deep breath in and out, and again and again. And then let him tap on your chest, then you do the percussion, then you listen to the chest of the patient. Okay? So you need to do all 4 steps on the patient in the SimMan stations. Okay? Is it clear so far, Ahmed? Any conclusion? No. Okay, now let's move to the next phase. We confirm that the patient's respiratory rate for the assessment. We confirm the respiratory rate whatever. 18 or 20, whatever. Okay? And based on your assessment, you need to start with something there and then. If there is a piece, then you start the patient solving the problem. Okay, so we are still doing. After you start with B, then we have to continue the horizontal progression because assessment of the patient, confirmation of the monitor, intervention of the patient, then create a list of your investigations. Okay? So, what are the possible interventions depending upon what you find? If the respiratory rate is very low or very high, if there are any calculations, if there are crackles, if there is any leaks or bronchi, you intervene. For the bronchi, for the leaks, you can solve with the mold, vanillin, okay? Or ibuprofen bromide, or both steroids. If the patient is bleeding very fast and there is a hypoxia, we suspect that the patient has PE, isn't it? You start the treatment, especially if the patient has a massive PE. For the massive PE, it is important to know the patient's blood pressure, but let's stick to the patient's pulmonary embolism. Out of those 4 H's, there are 4 P's, thromboembolic phenomena, pulmonary embolism. If we stick to that only, you are going to start the patient for the treatment for treatment. Okay? That's your intervention. And what are you going to do next, Mariam? What are you going to do next? You're creating your list, okay? D-dimer, CTPA, chest X-ray, ECG. You are just creating at the end, but you need to still verbalize. You need to still tell the patient, Mr. Smith, I need to get your ECG and chest X-ray. I may need to do a special test on the lungs to look for the clot, if there is any clot. Okay, and I will ask the nurse to do an ECG as well. Okay, and you have to be bit of multitasker when you are assessing the patient's chest. You can also listen to the murmurs and cardiac sounds at the same time. What are the parameters so far that we have trained on the patient? Visual assessment and the clinical assessment. And the visual assessment is any respiratory distress, pursing of the lips, use of the accessory muscles, okay, and on the clinical examination, inspection, palpation, percussion, auscultation, and on the monitor, what are the numbers of on the monitor of the respiratory rate, okay, and then you intervene, create a list of your investigations. Now, what are you going to do? Mariam, moving to C. Ahmed?
So in the same case,
Yeah.
I'll expose
To do what?
so to look for DVT.
So now we will go back to the to check that since stable.
Yeah. Check. Go back to A. Okay. Now, the rule of whereas we have gone through the horizontal progression into the past, into the assessment of A, assessment of B and C. Patient assessment, monitor, intervention, and list of the investigations. That's a horizontal assessment, horizontal progress. Then vertical progression is progression from A to B, B to C, C to D, D to E. Okay? For that, we need to go back. Every single time you complete one part of your assessment, you need to go back to A. Okay? We completed B, we went back to A and put them in combination and try to find, is the respiratory system stable? Okay? But before you go to C, you're going to go back to A. Okay? So which means that from here, coming down is not allowed. Coming straight to C is not allowed because your patient might have now started desaturating. You don't know what's happening. Every single time you are ready to move forward, it is important that you go back and go through all the reassessment, all the previous steps that you have done. You skip them immediately last. Okay, you intervene in B, you skip this. Okay, to come to C, you need to go to the previous step, and from there come to C. Okay, where you done C, from here coming to D is not recommended. Okay, so to come to D, you need to go back to A, and from there come to B. Okay, and from B you jump to D. Okay, you skip C because in C you just intervene. You start fighting fluid. Blood pressure will take some time to come up. The pulse will take some time to settle. Okay, it will allow you to interact every single time you've done a bit of assessment. It will allow you to interact with the patient because you are assessing the patient or talking to the patient again. Mr. Smith, are you okay? You're doing the reassessment of pain. Every single time you say a few words, then you look on the monitor, you find that the numbers are still stable, they are not deteriorating. But say for example, after completing C, you wanted to come to D and check the patient's glucose and all those kind of things. Instead of you coming to B, you went back and you started reassessment, and now you found that the patient's oxygen saturation is going down, so it is not allowed then in progress because there is a deterioration that has started happening in the background. While assessing D, the patient may die from hypoxia or very low respiratory rate, or maybe problem with the breathing, tension pneumothorax, or the hemopneumothorax, or the spontaneous pneumothorax, or anything. Okay? which is causing, or maybe opiate toxicity. So the patient has started deteriorating, that's why you are not allowed to B. Because A and B can kill the patient before D kills. Does it make sense? So after completing B and A and B, we go back to A, talk to the patient, Mr. Smith, you are right. Okay, the patient is talking, you're happy with the airway, look on the oxygen, okay, it's still stable. Let's move to C. What are the parameters that will tell you what the patient is stable, not in terms of his circulation? What will tell you, what are the parameters of your assessment?
So long peripheries,
Okay, how will you know that?
by touching,
By touching, okay. Capital refill time.
bulk,
Marianne, say something.
Burning, side
Hmm?
burning side.
Looking for cyanosis, okay.
so strong pulse,
Pulse character,
Blood
okay.
pressure.
Blood pressure, okay. How will you know that by just checking the patient? You need to monitor as well. The parameters that you can check on the patient.
Pulses on both peripheries.
Okay. Okay, yes. Okay, so we have the parameters to follow and to assess on the patient, and the parameters to confirm on the monitor. Okay, so what are the parameters of C which are on the patient? There are 4 parameters. Okay, we start with the, just to make it easy, capital T for time, peripheral pulses, character of pulses, and peripherals or peripheral input. Okay, so these are the 4 things that you will be looking for. Number 1, 2, 3. Okay. Mr. Smith, let me feel your fingers, okay? Let me feel your hand. If you bench it, 1, 2, 3, 4, 5, it has to be less than 2. Okay? Capillary refill time has to be less than 2 seconds. And you have done this, capillary refill time. Okay, Mr. Smith, let me feel your pulses. Let me feel your hands again. Okay, you're checking the pulses. At the same time, you're checking the character of the pulses. Can you feel the pulses and the good volume? Okay, and feel on the field as well. Okay, you can use 2 hands if you're skilled. If you can isolate, if you do not have any problem with that, by checking pulses on both sides at the same time. Okay, experts can do that. Okay, otherwise, feel one way. Is making sense? So you have done your assessment on the patient. The 4th thing is, please, let me feel your arms. Okay, your arms are very cold, or your arms are very warm. By assessing this, you are just simply getting an idea that the patient has very high temperature or normal or low temperature. Okay? And are you going to waste the time by putting the thermometer in the axilla or in the mouth or in the ear and wasting your time or doing the pulse count on here? It's spending 1 minute. The patient is dying. Okay? Near the monitor. Go to the monitor. You just quickly do the assessment. It takes just a few seconds. Let me feel your hand. 1, 2, 3, 4, 5. Okay. Just pinch the bulb of the finger and check for the refill time. Let me feel your hands. At the same time, when you're touching here, you're not only feeling the pulses, you're checking that the pulses are good volume or weak. Okay? So you are just trying to analyze pulses, either they are actually present. Okay? Good volume, I mean strong or weak. Okay? Peripheries. Are the peripheries warm or cold? Okay? Are the peripheries warm or cold? So these are the things that you go to when you touch the patient. Let me feel your finger. 1, 2, 3, 4, 5. Okay. Your examiner will give you either down or they will say or you will hear a sound from in the background. The patient's capital refill time is 2 seconds or 3 seconds like that. Okay? Okay? Is it making sense? So they will either tell you or they will tell you through the software or they will verbalize that the time is 2 seconds, 3 seconds. But now let me just incorporate this unit. Right? When you enter, there will be a beep, there will be noise as well in the background. It's not just silent one. Okay, now you look on the parameters on the monitor. So we have done assessment on the patient. Next thing is assessment or the confirmation of your assessment on the monitor. There are 5 things to look for. Okay? Pulse rate, heart rate, pulse rate, heart rate, ECG, blood pressure, and temperature. Okay. So there are 4 things to look for on the patient, whether it is time, peripheral pulses, whether they are present or absent. Okay, the current of the pulses, whether they are good volume, strong or the weak pulses, and the peripheries, are the warm or cold. But you confirm the temperature on the monitor. Now, if you look on the monitor, there is the top row shows you those 3 parameters: pulse rate, then the heart rate. Pulse rate is a pulse, and heart rate is a HR on that. And you look on the ECG. And ECG is one of the commonest thing that the students miss, or the doctors miss when you go inside. Okay. And that may be the only finding in all your assessment. Say for example, the patient coming with a dizziness, new onset of acute fibrillation, that patient has only this abnormality, no assessment. Is breathing fine, respiratory rate is fine, oxygen saturation is fine. Or the patient who is hyperkalemic, the patient is sent by the GP because the GP is worried. He did the investigations in the morning for a patient, this is a routine investigation, and GP received the result that the patient has abnormal blood results. And they send the patient to the A&E. You are the A&E doctor, see the patient. Patient doesn't know anything. Patient is saying, I don't know doctor, I went to my GP in the morning, just for the routine test, and I received a call. The nurse called me from the practice and she said, go to the A&E, your blood tests are not fine. That's all. Patient is not able to give you any history. When you talk to the patient more clearly, when you assess the breathing, they are breathing fine, no oxygen saturation degradation, there is no problem with the pulse rate, but when you look, there is a high T wave changes. But if you do not follow those parameters, you are very likely to fail the station because the only finding that you missed and you failed. Okay? Another patient coming with dizziness, coming with recurrent falls, he feels dizzy when he stands, otherwise he is talking, his glucose is normal, pupils are normal, breathing fine, there is no problem. The only abnormality that you may find in that situation is ECG. Okay? So that's why it's important that you ask the patient, if you have any heart problem, as soon as you identify that there is any problem with the ECG, ask the patient, do you have any problem with the heart? Or especially any, do you have any palpitation? Or you don't have any heart problems? Okay? Ask them. This will tell you whether this is an acute new onset or the chronic, because there are few scenarios for chronic as well. Acute limb ischemia has a fibrillation when you look on the ECG. Yeah, that is chronic. He is known to have that acute limb ischemia. But he stopped taking the medication. The patient with the PLAB, he has the ECG changes which are consistent with the acute fibrillation. And they're complying, they're taking warfarin and they develop disease. Okay? So you see different scenarios with acute fibrillation. There may be absolutely no symptom, as in case of worried patient sent to GP, no symptoms at all. Okay? Just an electrolyte imbalance, you do not have any investigation, you see the ECG is showing the T wave, or a tolerant T wave or something like that. Okay? Or to the minimal symptoms, feeling dizzy but no other problem, okay? Or severe symptoms, acute limb ischemia, or the PR bleed to the shock. Always make sure that you follow ABCDE. Always make sure that on the patient you check all those 4 parameters in this particular order as I'm teaching you today. Okay, start with the capillary time, check the pulse is present or absent, check the pulse is strong or weak, check the peripheries are warm or cold. Okay, and then you confirm your findings on the monitor, pulse rate, heart rate, ECG, blood pressure, and temperature. And you need to be ticking all those boxes in your mind. Okay, make sure this is your lifeline. If you start missing, if you start messing, okay, if you start becoming confused, do that. Relax, take a silent, deep breath, relax yourself, and start clicking the boxes. Okay, do not worry. Believe me, you will find something. No, if you want to create your own set of your parameter, you can do that. This is very convenient and I teach everyone the same. So if we are practicing with each other, he may have the one that I use, but you have your own, then you will start messing up if you're practicing. Try to follow something which is reasonable. I normally teach this way, so there is no convenient if you go to the academy and you don't have any Pakistani or anyone who you had been practicing with, maybe an Egyptian candidate or Nigerian, okay, but they will have the same structure. You will not be fighting with each other. Does it make any sense? Try to follow. But as long as you do that, make sure 9 boxes to tick. 4 on the patient, 5 on the body. Okay? Now, what are you going to do next? Zishan. Intervention according to the findings. Excellent. What are the findings? Say for example, capillary fill time. Let's talk about that one by one. Capillary fill time is high. What intervention the patient needs or may need? At least the fluids, isn't it? If the capillary fill time is 3 or 4, at least the fluid, if the peripheral pulses are present or absent, at least the fluid, okay, isn't it? The minimum intervention is at least the fluid, and the character of the pulse is very weak. At least the fluid, that's the minimum intervention. That if it's very warm or cold, at least a blanket or paracetamol with the antibiotics. Okay, if there is any change in the temperature, they all need antibiotics with or without a blanket. Okay? If they are very cold, very fees are cold, cover them and give them antibiotics. If they are very warm, give them paracetamol and antibiotics. That is an intervention. Isn't it?
If peripheries are very cold, not to engage the fluids.
You can, yes.
Maybe hypertension.
Yeah, so if the patient's peripheries are, so we are talking about the H's and T's again, the temperature is very high or low. Okay, what's the intervention based on that particular one single parameter? Okay, in combination, the patient may need many things, but talking about one single parameter, normality, the capillary fill time is very high. Okay, IV fluids. They may not need any other antibiotics or anything else. It's just a dehydration, nausea, vomiting, loose. Okay? It's a dehydration and a sickness medication. But you are not concerned that this is a viral illness. This place may have that by the food or someone else have the similar symptoms and blood pressure or just a bit of cold and flu, blood test, vomiting, and so on. Okay, or the patient coming with a hyperemesis, right there. Okay. No fever, no other symptoms of sepsis. At least the temperature, this capillary fill time is increased. The minimum intervention for this patient is a IV fluids. Okay. So single parameter abnormality based on single parameter abnormality, these are interventions. Then pulse rate, heart rate, ECG, we have to follow this. What if the pulse rate is high? We need to control the rate. It may be beta blocker, it may be absorption, it may be something else based on what you see. Okay, but this is because all of them are related to these four. They are related to the cardiac muscle and the cardiac activity. It is important to complete the assessment and see them together as I mentioned in the case of the respiratory system. A and B both make together a respiratory system. This makes, these are the parameters that will tell you if the patient is going to cardiac arrest or no. Okay? Peripheral temperature may not tell you. Okay? Unless it's very low and you see again you need to find some. If normally ECG where the temperature is very low, you are not worried about cardiac arrest. The things that can tell you that the patient is going into cardiac arrest, these are those parameters. This set of parameters. Okay, pulse rate, very high or very low, severe bradycardia or sinus tachycardia or the SVT or the VT. Okay, that means the patient is going to go into cardiac arrest. Okay, heart rate, we know about heart rate and pulse rate. ECG. ECG is showing some abnormalities, but you're not seeing any other major abnormality on the pulse rate, the heart rate, say for example, hypercalated, severely hypercalated. At the normal pulse rate, or maybe 105, 110, that you would not bother about normally. But now you see the ECG is changing. It's not just a normal sinus tachycardia. It's a sinus tachycardia with the ECG abnormalities and high testing. Okay, there has been hyperkalemia scenario that was being tested in the blood, so you need to get it. Okay, so that can give the patient cardiac arrest. So if you are trying to, after making the assessment of A and B, you are now trying to figure out, is the patient going to go into cardiac arrest? Answer is no. You are happy. Here, these are the four parameters that will really tell you, is the patient going to go into cardiac arrest? If the answer is no, then you are happy. Okay? And blood pressure, very high or very low. Very high blood pressure can cause what? Stroke. Stroke? Okay. What else?
Aortic dissection and ruptured aortic aneurysm.
Aortic aneurysm, renal shutdown, okay, stroke, hypertensive encephalopathy, the patient may start becoming confused or hallucinating, okay, or the patient may be talking to you normally, he is asymptomatic, as you are just talking to the patient, all of a sudden he collapse. Okay. Or all of a sudden he starts vomiting. All of a sudden he starts saying, oh, I have severe pain, it's not coming back. Abdominal problem. Aorta has no rupture. There was no symptom to talk because the patient was chronic hypertensive state that was going on. The blood pressure in the abdomen became very high, ruptured the aorta. So this is why even if the patients are asymptomatic hypertensive, they need the treatment. Okay? You might have seen in your families or the friends that are closer to you many of the time when you check your blood pressure, someone's blood pressure, and you find out it's 109. You say, Dr. Sahab, koi masla nahi, mainu to pata nahi lag raha. I have no problem. Okay? I have no problem with this. I don't know. You were saying that my blood pressure, they are at high risk because all of a sudden they can develop abdominal proton dissection or rupture. All of a sudden they can develop hypertensive. They also need the treatment, even if it is asymptomatic or very low blood pressure. That is a shock, isn't it? So based on that, we will implement assessment of the patient, confirmation of your assessment of the monitor, and intervention based on your assessment, investigations based on your assessment. You may also give the patient a catheter. We can also ask the patient if they have went across urine last time. Okay, ask those parameters as well. They will be helpful. If the patient is severely hypertensive or hypotensive, if the patient is in shock or pre-shock, okay, give them for the sepsis or the catheterism. Yes.
Did you check the heart sounds in this?
Sorry?
The heart sounds, did you see the heart sounds?
Yeah, you can. As I mentioned before, if you remember, I said that you can listen to heart sounds in B when you are listening to the drugs.
No, I'm asking will we do it or not? Because you said 10 cannot, right? So there will be muffled heart sounds.
Yeah.
So to do that, how to listen?
Yes, please. Yes. So, this is what I'm saying. You can find the muffled heart sounds in breathing when you are assessing, when you are listening to the chest. Okay, you can also listen at the same time, and your gender will not mind that. That will not go against you because you are multitasking to save the time and reach to the diagnosis sooner than later. Okay, so don't worry about that. You can do that. You will not be penalized. You don't have to go back and listen to test twice. But if you are very fan of that and you want to show your gender that you are doing them individually, you can do that as well. Okay, you can say, okay, now let me listen to test, and that will also be very good. Okay, it's up to you. I'll give you this leverage. You choose what you want. Okay, after feeling the pulses, you can say, okay, now let me listen to the heart, and just listen to that. Okay, very good. You can, this way you can create a set of 5 rotation, 5 rotation. That's good. Yeah. So you can do 5 on the patient, 5 on the monitor, 5 things to do on the patient, which are different time pulses and the character of the
I was
pulse.
asking you before, was in these 5, is there a priority to check blood pressure before 12?
No, there is no priority.
That
No, there is no priority. Okay, but you need to check
all
on.
5. But there is no high priority that we check blood pressure before 12.
No, because if you're checking just only one thing, it means that you're not completing the assessment. Okay, you're not going to start the treatment for every single thing.
So I can even check the ECG in the last step.
Yes. You can check the ECG analysis. Okay. Anything that you want to ask? Ahmed, what are you going to do next?
Next, we are going to do intervention. We will be doing, if we need any investigations.
Okay. Investigations like what?
Like, if we are suspecting a ruptured aortic aneurysm, we will
What are the investigations?
say CT ultrasound.
Huh?
We can do ultrasound of it.
And maybe we can do radiological investigations, we will send blood cultures for
Yeah, so you need to create the list based on your assessment. Capital for time, okay, peripheral temperature, and all this based on your intervention. You do the assessment. You create a list of your investigations that may include or will include ECG, okay, bloods, including full blood count, UAEs, LFTs, CRP, and probes, and if there's any other issues based on that's UAEs, any other investigation if you want to read, for example, if you're worried about the bleeding, postpartum hemorrhage or anything, then you do the group and say, okay, we do the cross max, okay, all those things. Anything else that you may think of? Then we see echo, yes, echo. We can do echo, but not necessarily you are able to, you need some senior to do that, and again, it will not be authentic or authorized because it has to be done either by the cardiologist or someone. CT, yes, CT, if you are suspecting anything, so we create a list, okay, but you do not wait for that. Okay, but what we need to do is make sure the minimum investigation up until now you have done is VPG. or ABC. Okay. That's the minimum investigation that you must have done before to complete your assessment. Okay. It can be done, the VBG is an instant investigation, it gives the blood cells instantly. There are two parameters that you will find. That's a pH, PaO2, that's a PaCO2, HB, potassium, sodium, the calcium, magnesium, bicarbs, and then base excess, and glucose, lactate. So these are very good number of investigations that the parameters that could very tell you. Okay, so do this. That's the minimum assessment, minimum investigation that you should have in your hand before you complete your analysis. Now we need to take the geometry. Okay, in the meantime, it will be half an hour, 45 minutes, anyway. How long? What do you think? Where should we meet again? Let's meet. What time is it now?
120.
Okay. मौलवी साहब इंटरव्यू करता है ना वो कम छोड़ता है
से 1:30 बजे
1:20 हाँ
1:30 बजे होगा तो 2 बजे खाली
हाँ so let's meet at 2 o'clock okay share the link again in your stream again okay